Hey everyone, this is Teresa Webina. I am your coag coach in hematology, and today I will be talking about a coag vignette. It's on a young woman with bruising. We'll be talking about making the diagnosis. So the case is of a young woman in her 30s who presents to her PCP in the outpatient setting with 1 week of bruising. I want you to commit to a diagnosis. Does this patient have physical abuse by a violent partner, immune thrombocytopenia, thrombotic thrombocytopenic purpura, vitamin C deficiency, or acute leukemia? Okay, now let's talk through keys to the diagnosis. So we have the elements of history, medical, family, and social history, as well as the medications, and then we have the elements of diagnostic evaluation, including the physical exam, lab studies, and imaging. Let's go through each one by one. The medical history, we know that she has hypertension, a prior C-section, and depression. Now what's important to note is that she's had a prior C-section without any clinically significant bleeding. That's important to let us know that this is unlikely to be a congenital problem. This is most likely to be acquired. Family history, early coronary artery disease in a father. So this is, again, maybe not related. Social history, she's a single mom. She lives in a safe environment. There's no concerns for partner abuse. She does use tobacco. That probably is not related to the bruising, but it may make us think of the possibility of underlying disease. Her medications are significant only for albuterol inhaler as needed, so unlikely to be contributing to her bruising. Let's look at the diagnostic evaluation. On physical exam, we note that she has extensive bruising on her bilateral arms and legs. The lab studies are going to be discussed later. And then the imaging, it's important to note that imaging is actually not indicated based on her findings so far. Okay, let's now focus on the lab studies. And we're going to start with the CBC. So when we look at the reference range and look at what her labs were 14 months ago, she had a slight thrombocytosis. Today, she actually has a thrombocytopenia along with a slightly elevated white count and a low hemoglobin and hematocrit. So she has new onset anemia and thrombocytopenia with leukocytosis. Let's now take a look at her chemistries. So when we get a Chem 8 panel, we're noticing that her labs are entirely normal. So that tells us that there is unlikely to be an underlying systemic issue going on. Let's take a look at her other chemistries. We note that her ALT is slightly elevated and her bilirubin is slightly elevated as well. And the ALT may be low due to B6 deficiency. You can see that in a smoker, but it's not clinically significant at this point. So our focus really is on the hyperbilirubinemia. Now, what are our next steps? She has leukocytosis. We should get a white blood count differential. She has anemia. We should get a reticulocyte count. And then we should also get a blood film as well. She has thrombocytopenia. We want to see the blood film. And she has hyperbilirubinemia, so we should definitely look for hemolysis. Okay, we start with the white blood cell differential. As you can see, her white blood differential is perfectly normal. Next, we think of evaluating the anemia. The reticulocyte count first. We notice that she has elevated reticulocytes, both count and percent. Now, let's take a look at the blood film. For thrombocytopenia, you're also going to need the blood film. You can see that she has fragmented red cells that are consistent with schistocytes. So, the result is that she has evidence of microangiopathic hemolysis, but let's take a look at our hemolysis labs. Yep, we're seeing that she has an unconjugated hyperbilirubinemia, though mild. Her LDH is significantly elevated above normal, and her haptoglobin is low as well, and that does indicate that hemolysis is present. So, she has a microangiopathic hemolytic anemia. What's our next steps? Our next step is to calculate a plasmic score to determine the pretest probability for TTP. P for platelet count less than 30,000, she scores a 0. L for hemolysis, she gets a 1. No active cancer, she gets 1 point. No solid organ or stem cell transplant history, she gets 1 point. MCV less than 90, she gets 0 points. INR less than 1.5, she gets a point. And creatinine less than 2, she gets 1 point. Total score is 5. And so this means that she is an intermediate risk of severe ADAMTS13 deficiency. We are empirically going to begin plasma exchange while we wait on the results of the ADAMTS13 activity. And so when we got the results of the ADAMTS13 activity, she was 1%. And this diagnosis is consistent with thrombotic thrombocytopenic purpura. What are our take-home points? When someone presents with new onset bruising, you should take it seriously, even if the patient looks great. If you have anemia and thrombocytopenia, you want to definitely evaluate it with a blood film. And finally, if microangiopathic hemolytic anemia is present, evaluate for TTP. This ends our coag vignette, a young woman with bruising who turned out to have thrombotic thrombocytopenic purpura. Thanks for watching.